Dr. Eskander, tell me this, and we talked about this a little bit before. So Donia said she had a family history of cancer. Her dad had cancer. So do women with ovarian cancer, is it common to have a family history? What kind of mutations can you see? What should they be aware of?
So this is really an important topic and very timely. We've learned a lot about this over the last 5 to 10 years, a lot more than we had known previously. And the reality is there's a proportion of ovarian cancer patients that do have a genetic predisposition to developing the disease. And we're learning more and more about what these alterations are that may predispose patients to having ovarian cancer or fallopian tube or primary peritoneal cancer, all of them as one family. Based on the information that we have now, we think as many as 15 to 20% of patients who have a high-grade serous ovarian cancer can harbor a genetic alteration that predisposes them to developing these cancers. And most commonly, it's the BRCA1 and BRCA2 mutations. There are other mutations that are involved in these family of genes that are necessary for DNA repair. Mm-hmm. And we're identifying additional ones like RAD51C that also increase the risk of ovarian cancer or breast cancer. And I think with time, we're going to continue to add to this list. So we have a 15 to 20% right now where you have a genetic inherited predisposition. And that's independent from the risk that may arise with genes and alterations that we don't know about yet, but that may add to that percentage in the future. So it's not a meaningless number or a small percentage by any means. It's a true number of patients who have these alterations. And this has very important impacts on diagnosis and treatment and family and education, et cetera.
So when patients see you with ovarian cancer for the first time, do you test everybody? Let's say Donia had a family history. I think her father had esophagus cancer. We were talking about this before. But do you screen, let's say people come and say, hey, I have zero history of, family history of cancer. Do you screen everybody, or do you screen specifically patients like Donia who come and kind of talk, who kind of give you a new family history of cancer?
So, we've gone away from using the family history as a guide to testing, and that's based on literature and data that we've learned over the last several years. We test all epithelial ovarian cancer patients. Really, all ovarian cancer patients now are recommended to undergo genetic testing, and in addition to that, if the resources are available, genetic counseling to better understand. Admittedly, physicians aren't very good at harvesting and acquiring a good comprehensive family history because it's very time intensive. So there may be things that we think don't exist that truly exist. And there's data that suggests that up to 50% of the women who have a BRCA alteration in cancer may have no family history that they're aware of before they were diagnosed with their cancer and identified to have a BRCA mutation. So for those reasons, we really encourage and counsel, and it's really common practice now to test all of our ovarian cancer patients for an underlying genetic predisposition.
So Dr. Eskander, which one is more common, BRCA1 or BRCA2? Or BRCA1 or BRCA, I should call it.
Yeah, BRCA1 mutations are more common than BRCA2 mutations.
So you test them all, and let's say somebody has a positive, has a mutation. Do you normally refer them to genetic counseling so that they can talk to a specialist for that? Do you offer them that yourself?
Yeah, so I will talk to the patient, and if they have family members present with them during the visit, talk to them about the results, explain what the results mean. But I do always refer to genetic counselors. We're fortunate enough to have a very good genetic counseling program. And the reason is because, again, to invest the time that the patient and the family deserves to truly understand the implications of these genetic alterations requires, I'd say, at least an hour and 15 minutes, and to really sit down with additional family members, talk about and answer the questions they may have that the patient may not have, but their sister or their brother or their child who accompanies them to the visit may have, is really important. And having a good genetic counselor who's able to sit down and review the implications is a great resource.
And what kind of reactions do you normally see? Or some of the family members go, I don't want to know about it, or like tell me about the range that you see.
It's a mixed bag. It's always hard. Sometimes patients actually carry a lot of guilt when they realize that they are a BRCA mutation carrier, because they feel like now they are putting their children at risk, or they don't know what the impact may be on their siblings. And I try to reassure them and say, no, what you've done is essentially maybe given your child an opportunity to be saved by never being diagnosed with the cancer and having a risk-reducing intervention. But the reaction is varied. Some patients have not very much of a reaction and say, okay, we'll deal with it and I'll have to speak to the genetic counselors. Some carry a lot of guilt. And others, honestly, they don't really even understand what any of this means. And it takes a lot of time for them to truly process and understand what is this genetics and what does this mean to have an inherited alteration, and to connect the dots to how that might impact their family members, children. So it's hard to predict, but it's a variable reaction.
So much information. Dr. Hurst, what do you think about that kind of reaction of saying, I'm fine right now, and I may be carrying this gene? And from both from the patient side and from the family member side.
Yeah, I think that has changed a lot recently, especially with more commercially available, direct-to-consumer genetic testing. People are getting more familiar with what some of that means, but our patients have a really wide range of backgrounds of understanding what is genetics and what do these tests potentially mean. But it can be huge, whether it's a younger woman whose mom is there and feels like, oh my gosh, did I give this to my daughter who's now ill? Is the patient feeling like now I've put my children at greater risk? There's a lot of reassurance around that we can't control our genes, and what is, and we now have information that can help us hopefully take steps to mitigate whatever risk we now know we have.
I think that's very important, because it's really important for patients to understand that it's not their fault, frankly. It's just that you inherited these genes, and now you have the information that you can act on to actually inform. I think just like maybe Donnie or Dad somehow had this thought process, of saying, hey, remember, if you're in your 50s and everything, if you don't feel well, go to a physician. And I think that that worked out in your well-being.